I'm Iqbal Malik. I'm a consultant cardiologist at Hammersmith Hospital, Imperial College, London. And my topic is post-TAVI pacing and how to avoid it. So let's crack on. The plan of action will be that I'd like to see if we can actually predict pacing. If we can, then who do we prophylactically pace to avoid calamity in the cath lab? Which ECGs worry us after the TAVI procedure and make us do something? And who cares anyway? What if we just put a pacemaker in? Is that so bad after all? I think we have to understand the anatomy of the AV node and the bundle. So the conduction system runs in the membranous septum in between the right coronary sinus and the non-coronary sinus. And so when we're placing a TAVI valve and it nudges the membranous septum, then we have a danger of nudging the bundles. And you can see that the left bundle is obviously going to be closer to the TAVI valve than the right bundle. And that illustrates two issues. Number one, that left bundle branch block is more common after a TAVI procedure than right bundle branch block. And number two, that if you already have right bundle branch block, then nudging the left bundle could end up with a calamity. An anatomical description of the same is over here. And the idea is that this diagram is true reality because here again is the membranous septum. And here is the area of the membranous septum where the bundle may run. Of course, pacing rates are coming down over time, even though patients haven't suddenly changed their anatomy. And that's because TAVI operators have become better at trying to avoid pacing. And we can discuss how that might be. So this is an Edwards valve, and you can see the pacing rates are now well below 5%. For the self-expanding valves like the Medtronic valve, pacing rates are also coming down, mainly by adjusting the height of the valve implantation. So there are many valve types, and one message is that balloon expanded valves in general have a lower pacing rate than self-expanding valves because self-expanding valves have to have a push out force that is not required for the balloon expanded technology. So topic one, can we predict pacing? Well, the ideal test would be having a negative predictive value of nearly 100%, so that if the test showed that you weren't going to pace, you absolutely were not going to need a pacemaker. The prediction tools are many, and therefore almost too varied, but I'll take you through the ECG factors, the patient factors, and the procedural factors. So the most dominant factor, as we've described, is right bundle branch block, but bifascicular block obviously carries risk, even left anterior hemiblock. If you have bundle branch block, the duration of your QRS suggests the age of your conduction system and whether you're more at risk. Atrial fibrillation, not a major factor. What about if you actually did more fancy electrophysiology? We'll talk about that, but in summary, if you're getting wanky back after the procedure, the pacing risk is higher. And if your HV interval, if you've already done fancy electrophysiology, would also be a risk factor. Patient factors obviously are related to the age of the patient. The older you are, the older your conduction system. Gender, so men tend to have a higher risk of pacing. And the calcium distribution and the level of calcium in the valve and the LVOT. So that valve with calcification is going to probably make more of an impact on pushing on the valve than if there was a lower calcium score. The height of the membranous septum, I will go through in detail. If you could actually map out the position of the His bundle, is it further away or closer? That would be useful, but that is very hard to do. And then, of course, the shape of the valve outflow tract as well. In terms of procedural factor, the height that you place your valve. I tend to say now that the previous years have had a TAVI placed as high as possible to avoid pacing. I think we're now discovering, as we're doing more TAVI and TAVI, that a lower TAVI procedure might make coronary access easier. So there'll have to be a balancing act done at some stage. I've mentioned that balloon expanded valves have a lower pacing rate, and actually it's not without a tongue in my cheek to say that the name of the doctor is also important, because the way you do the TAVI procedure will definitely affect your pacing rate. There's a question mark about whether beta blockers actually change the pacing rate. We feel that, of course, they hit the AV node, but stopping beta blockers in someone with left ventricular hypertrophy and a need for them may actually risk heart failure. And actually then restarting them afterwards might unmask a problem that wasn't spotted in hospital. So we've now moved to not stopping beta blockers in any case. So prediction by ECG, we've mentioned right bundle and the bifascicular block. Left bundle, of course, the conduction system is aged, and therefore that will have a higher risk than if you had no bundle branch block. And what about electrophysiology studies? Obviously, if you have complete heart block or trifascicular block, you should have a pacemaker before you think about a TAVI procedure. If you're going to do EP testing, this is not a transfer to the electrophysiologist. We need to having it done in the interventional lab done by the interventional cardiologist, because transferring a patient from one lab to another, there is no time, and certainly there's no money. Of course, there are some American studies which suggest that it can add some benefit, but of course, that is also driven by the fact that you can also bill for two procedures, which we cannot do in the UK. So if you do test patients who have Wenke back, so you've done an electrophysiology study, you've paced rapidly, you've discovered Wenke back, then those who do have Wenke back on electrophysiology study by rapid pacing have a higher risk of pacemaker. So a simple thing that could be seen on the surface ECG Wenke back phenomenon seems to have some benefit. What about in those with left bundle branch block, a group of patients that we find in TAVI that could have electrophysiology studies to predict what is going to happen next? Well, this group used an HV interval of 55 milliseconds as a cutoff, either getting an ILR, a loop recorder, or getting a pacemaker if the interval was larger than 55. And it is reasonably predictive. So in the high AV block group, the pacemaker group, which were the ones who had more than 55 milliseconds, that was quite predictive, because in fact, 53% of them ended up having even higher block. They didn't start with complete heart block, but 2-to-1 block or complete heart block occurred in over 50% of the people who'd already had a pacemaker. And therefore, this HV interval does seem to be predictive. Perhaps most interesting, and something we could do in the cath lab, is looking at the height of the membranous septum on CT and then modifying our procedure as a result. And the message really is, if your membranous septum is more than 8 millimeters in height, and if you have no calcification in the LVOT, the pacemaker really is much less likely. And again, if the implant depth of your valve is more than 2 millimeters greater than the membranous septum, in other words, the septum is tall, your membranous height was high, and therefore your gap between the two was large, you're going to avoid a pacemaker. Whereas let's imagine a membranous septum of 4 millimeters and your depth of deployment was 4 millimeters, a pacemaker is very likely. What about the anatomy of the septum? Well, if you oversize your valve, you're going to push harder on the LVOT and that membranous septum and increase the chance of a pacemaker. That seems fairly evident. And so the question is whether you're a perimeter person or you're an area person. I tend to be a perimeter person, and therefore in this particular example, where the perimeter suggests a 20 millimeter sapien or maybe just about a 23 sapien for the 340 area, I'd probably choose the perimeter. But you can see for an Evolut valve, if you use perimeter, you'd be ending up with a 23 valve. If you use area, you'd be ending up with a 26 valve. And this calibration, I think, needs to be used if you're trying to avoid pacing. So the anatomy, the valve to annulus ratio is what we're really discussing. And for each little bit of increment, you increase the pacing rate. And of course, if you do have a pacemaker, is it bad? Well, this group actually showed that the risk of hospitalization or hospitalization and mortality even was higher if you had a pacemaker. The next issue is right bundle branch block. And I've mentioned why that might be, because if your right bundle is already affected, and your conduction system has the left bundle branch block in it, just in this zone between the right and non-coronary cusp, especially if there's calcification, your pacing rate goes up. This group also showed that if you were older, your pacing rate went up, which obviously seems very reasonable and obvious. So if you do have right bundle branch block, then should you be doing something even before or after hospital admission? Well, this used Body Guardian, which is a way of monitoring the ECG in people who had higher degree block to see if there was a higher rate of pacing. And indeed, if you had right bundle branch block pre-TAVI, then the Body Guardian suggested that there was almost a 50% chance you'd get high degree block. And therefore, if you monitored enough, why not just put a pacemaker in advance? So we're moving on to who should we pace prophylactically, therefore, if we can predict pacing. So what we actually do is if you have right bundle branch block, say left axis deviation, or even trifascicular block, you should have a pacemaker in advance. If you have left bundle or a right bundle even, then I put a formal temporary pacing wire in. And actually, I tend to use a balloon expanding valve rather than a self-expanding valve. And anything else, then either valve will be suitable, and we just pace using a safari wire. So what about post-TAVI? What worries us? Well, what would worry us afterwards is, again, those very dramatic ECGs, if they've developed after the procedure. If you've got trifascicular block on the ECG, we would probably put in a pacemaker. And if you have bifascicular block, then actually, logistically, I would say that putting in a pacemaker there and then might actually be worthwhile. But the very least, if we were going to be bold and see it might recover, especially with a balloon expanding valve, then leave a formal temporary pacing wire in. If you just have left bundle or right bundle and there's been no evidence of heart block during the procedure, then they get put on a formal monitoring for about 48 hours to make sure no further block occurs. And anything else is put on telemetry. And if you do telemetry, then who can you avoid putting on a more monitored bed and therefore more expense and more intervention? Well, if in fact you used a balloon expanded valve, you've got sinus rhythm, there was no AV block, no bundle branch block, then there is a group that said no telemetry was required. We're not bold enough to do that. We will put them on telemetry even if we're doing day case TAVI. However, if you get bundle branch block, then they were using telemetry until the 12-lead ECG was stable for 48 hours, which I think is much more reasonable. This sort of fits in with the ESC guidelines, where if you've got high degree block or alternating left and right bundle branch block, a permanent pacemaker is needed. If you have a pre-existing right bundle branch block and further issues on top, as I've said, a permanent pacemaker is needed. And the others, my real worry is a very, very broad left bundle, and I would probably put a pacemaker in for that as well. And everything else, we'll just watch and wait. So does new left bundle branch block have a relevance? And I think it does. There's this study which suggests that actually mortality rate goes up, and that if you have a pacemaker, then that may actually prevent mortality. It's, I think, the very broad QRS that is particularly worrying. So my view on left bundles, that it occurs in 20 to 30% of cases. Actually, often it is persistent. And if it is persistent, then 10 to 20% will end up with a pacemaker. It is not good for your ejection fraction. It is not good for your NYHA class. It's uncertain whether you live longer or shorter, but I'm pretty certain you live less well if you actually develop left bundle branch block. So it's something to avoid. So what about a pacemaker? Well, is it really so bad to put a pacemaker in an older patient? The world is divided. So this study of over 10,000 patients suggests it does not affect one-year outcome. That, of course, the ejection fraction is slightly different with or without a pacemaker because you're not coordinated. Now, this pacemaker is standard RV pacing. In our hospital, we've got a lot of his bundle pacing or left bundle branch block pacing, which actually returns your conduction towards normality and may eventually take over from biventricular pacing. But this study of almost 10,000 patients, again from the TVT registry, suggests actually it does make a prognostic difference. It's fairly obvious that as you get older, your pacemaker rate is higher, your conduction defects make it higher, self-expanding valve makes it higher. But more interestingly, with a pacemaker, you get a longer length of stay and a tend towards a change in mortality. So pacemaker, if it can be avoided, probably is a good idea. One study suggesting that actually a pacemaker might be protective. So this study showed that left bundle branch block had an increase in cardiac death, but if you put a pacemaker in, that mortality signal was taken away. So I think a pacemaker certainly does affect your ejection fraction, a right ventricular pacemaker that is, and that you would try and avoid it if it possibly can. I think it would make your LV work less well, and you may have higher heart failure outcomes. So if it is a pacemaker that you put in, well, is it used? And this study would suggest that you have in almost 45% of pacemaker patients who've got a pacemaker have enough AV conduction to tune it down. And I think even if a pacemaker goes in, looking again and making it work less of the time would mean a better ejection fraction and probably less admissions with heart failure and a better quality of life. So if you're going to put a pacemaker in, the minimum use is important. We are moving towards a very rapid discharge. And our key issue is not the groin anymore, but are we going to have a patient who goes into complete heart block? And there is a small instance of late complete heart block, which we have to worry about. So the patient we can send home has no porcelain aorta, a low calcium score, starts off with a normal ECG, has no complications or conduction abnormalities, and post-procedure, the QRS hasn't prolonged, the PR interval hasn't lengthened. So I think the answers to the questions I posed were, can we predict pacing? Well, right bundle, especially with high degrees of block, I think we certainly can. We should be prophylactically pace. To be honest, we now no longer prophylactically place every right bundle branch block, but we will do if there's right bundle and left axis or high degrees of block shown previously. Otherwise, we'll try and hold off the pacemaker because of the worry I've mentioned. Post-TAVI, a very long left bundle branch block, and also if complete heart block has occurred during the case, makes us worry. So if you put a pacemaker in, is that bad? I think it is. And if it is used, you should minimize it. So how do you minimize the risk of pacemaker? Well, a balloon expanded valve placed very high, and this is placed with the lucent line, is probably going to avoid it. High deployment takes some finesse, but it's perfectly safe. It's my standard policy for the last 2 years. And a Medtronic valve or self-expanding valve, again, a very high deployment, maybe a cusp overlap view, and about 4 millimeter deployment is perfect. So back to our prediction tool, and I would say that we've covered the ECG factors, we've covered the patient factors, and we've covered the procedural factors, especially the membrane height versus the TAVI height, the sizing issue, the balloon expanded valve. And I go back to the name of the doctor, because the way you do a procedure obviously affects outcome, and the medication we don't change. Thank you very much for your attention, and I hope to join in person if at all possible.